To the interactive session with the doctor organized as a part of Collaborative Studio on Hospitals, mentored by architect Nandini Bazaz. We are currently in week 4 of the studio, and the students have been familiarized with site analysis, concept development, and programming in hospital design. Before moving to design, the faculty, students, and us at ASH felt it would be great to understand the experience of a space from a user's perspective, especially doctors in a hospital. I would like to introduce the speaker of the session, Dr. Pranav, who would take us on a walk through a hospital from a doctor's lens. Before moving further, I would like to thank Dr. Pranav on behalf of Team ASH and the colleges attending this session. Thank you for taking out time from your extremely busy schedule to join us today. Thank you for being a Corona warrior. Dr. Pranav Balakrishnan received his MBBS degree from Kasturba Medical College, Manipal. He was interning at different hospitals in America as COVID was rearing its head. And Dr. Pranav returned to India just as the COVID pandemic was gaining speed. He is currently working in Medica Super Speciality Hospital, Kolkata as the COVID coordinator. They grew capacity from 20 COVID specific beds to over 130 now and have treated over 1,300 COVID positive patients in the hospital. He has also helped set up and run the home isolation monitoring system where they successfully treated 800 plus patients at their own homes. He hopes to join a general surgery residency program in America next year. This session is moderated and led by students. Other than the student moderators, if the audience has any questions, please type them in the chat box. There is 1 hour interaction and we will be taking the questions towards the end if the time permits. Kindly allow me to introduce the colleges and the student moderators. We have Devi Devikala from AUCE, Alvira from PHCOA, Abhinaya from SRM SAID, Radhai from SRM SEAD, and Saida from SOA SIT. I'll quickly read down the questions for the first section for Dr. Pranav. So the first question is, how and where would you like your cabin to be in a hospital? Second, what kind of subspaces or facilities are available for staff, nurses, doctors, and other staff? Staff area should be given at every floor for one common staff or one common staff breakout space. What do you think? Is there any hierarchy followed while designing doctor staff's quarters? If no, do you think there's a need of such hierarchy? If yes, what kind of things are to be considered while designing one? What kind of facilities should be provided in break rooms for reducing stress and fatigue, and where should they be ideally located? Can you recommend any methods to better mental health for both medical workers and patients? Next, what kind of room facilities are expected by a resident doctor and what is the reality? Next is, what are the additional spaces that should be provided for a doctor and a nurse apart from the consultation room, nurse room, and a staff room? I would like to hand over the mic to Devi from AUCE now.
Good morning, sir. I am Devi Devakala from AUC Vishakhapatnam. Firstly, we want to salute you for being a doctor and saving thousands of lives. And so coming to the first cluster, the questions are related to the basic facilities of the basic users such as doctors and patients. So I would like to go to the first question, that is, how and where would you like your cabin to be in a hospital? So like near in the ground floor where there is a high patient flow, or in the upper floors. So what's your answer for that?
So I think Indian hospitals are also moving towards sort of the Western design for this, where there is a common suite of OPDs where the patient interactions happen. So that's usually located on the ground floor where departments come in by turn. There's appointment-based system, and it's done like that. And the individual doctors have their own cabins elsewhere. So there might be like an administrative building where all the offices are there. So like for administrative staff as well as individual departments. I think it's important more so now because with COVID and infectious diseases like this, it's important to have that barrier where there is patient interaction and there is an area which is considered safe. So I think having a cabin which is my office space where I can have my things kept on a regular basis, where my research books can be there. My personal space should be separate from the common OPD space where different protocols are also followed.
So, sir, when you're talking about these certain things which you require to be in your own subspace, so is there a particular hierarchy which is to be followed while designing or arranging these spaces? As in, you said for the admin, there's a different block, for doctors, there's a different suite. And what kind of facilities do you wish to have, or do the staff wish to have in their subspaces so that it gives them a very positive feeling when they get into their suites or their spaces?
So there definitely is a hierarchy in terms of even amongst doctors. There's a hierarchy depending on how senior the individual is. So the more senior doctors will also have a small meeting area, sort of space where the team can come discuss cases, or they want to have a class or something like that. That can be in the doctor's main room itself. Uh, Obviously, size is something that they look at. So most senior doctors want more room, so you'll have space for books. They don't usually have any medical equipment in their personal space. So similarly, if you move to admin staff, again there will be a hierarchy within the admin staff, where you have meeting spaces and things like that. Senior doctors don't always spend the night in the hospital. They'll have the junior doctors doing that. So even then, they usually have like a sofa or like a convertible sofa with a bed kind of a thing in case they need to spend the night, they have a late surgery or something like that. And then when you go down to residents and the more junior doctors, they usually have shared spaces. So you'll have a desk with a cupboard attached or something like that with a desktop or a laptop where they can work. Nursing staff don't usually have individual spaces. It's usually the nursing superintendent who will have their own room, but the other nursing staff have offices where they work. Otherwise, most nursing staff have their respective wards where they're supposed to be at. So they don't really have a separate private area or personal space in the hospital itself. But I think main things are storage space, having a table, um, having for the residents, maybe even a shower area and a place to sleep.
So, for the residents especially, does cooking area matter, or is it the common canteen or the cafeteria where they have to be linked or something like that?
Um, so in Kasturba Medical College, there were multiple on-call rooms where the residents usually took their food and sat down and ate there. But they also use the common canteen area, which has a reserved area for staff. So it's the common canteen area will have a barrier between where the patients sit and where the staff sits. So that is something that is often done. But definitely, I think having a break room where you have at least like a microwave, maybe a fridge to keep your food uh, cold or whatever, and maybe a coffee machine or a kettle at least will help with residents who are working throughout the day. In India, the work hours are not even restricted. So residents do 36-hour shifts and then do 12 hours off and then again next 36-hour shift, at least in the beginning. So I think that sort of space is important.
So, when you're talking about the doctors in India, as you correctly said, there are no restricted working hours. So, these breakout spaces should, like, what should be their ideal location? Should be they placed on each floor, or should be on a specific floor in the center of the building, or should it be at the backside with a rare entrance, or should it be connected to the IPD section? What should be the exact location that is ideal for the staff?
I think floor-wise makes sense. Not so much in the OP area because the outpatient area again, like I was saying, a common OPD suite is better. So floor-wise in the IP section is a good idea because there is a sense of camaraderie on the floor itself where people are working together day in and day out. So having that close-knit group also helps with patient outcomes where people are talking to each other, communicating, and they get to know each other better. So I think a floor-wise approach is better than having a central area because there is doctors and nurses and all of them do get territorial with their break spaces. So I think having a couple of them sprinkled across the hospital is better.
aesthetics of the space and color actually work for the doctors and the staff as well as they do for the patients? Does it play that importance while designing a staff residence or a staff breakout room, the color therapy, these open spaces and the nature?
So I'm not so well versed with like what color is good and what color isn't, but I think just exposure to natural light is important. Like in America where I was working, we used to get to work before the sun rose and left after the sunset. So our only exposure to sunlight would be if there were some windows letting the sunlight in. So I think that would be great in a break room, not just in the break room, but also more of that in the wards for patients, because patients also, most wards are like, dull and congested, and there's so many patients around. Because in India, we have the general ward system where you have 20, 25 people in one hall area and not individual rooms. So that would help them, I think, feel, because patients are in a hurry to get home just from where they're staying, whether or not their disease process is completed. So I think letting them feel a little more comfortable by just exposure to light, having better ventilation and things like that would help.
Okay, so I think the students have completed the first section, facility related. We can move on to the next section. So I would like to hand over to Alvira for this section. She can speak her question for this. Alvira, you are on mute.
So the next segment is about hospital services related. So since the hospital staff is the first user for the hospital services, and services are the core of any functional hospital, so that plays a very important role. So the first question is, how do the doctors enter to the hospital and reach their respective departments? And just like the detailed circulation on their movement inside the hospital, or how is it different from the public circulation?
So I think most hospitals have a separate staff entrance, but it's not really enforced for doctors. Doctors tend to just enter from the closest from where their vehicles are parked or whatever. So at the hospital I'm currently working at, there is the main lobby entrance where patients also enter. That's where the doctors usually enter from. Whereas in KMC Manipal, there was no staff entrance. It was all because KMC Manipal just kept growing. So it's a maze that they just kept adding on buildings and wings and things like that. So they have multiple entrances and exits, and you just enter from wherever is convenient. All staff and all patients enter from wherever is convenient. But I think it's important to have some sort of a segregation in terms of circulation, because the kind of screening you can do, especially now, you need to do screening at entry points for symptoms of COVID, but also in general, like you need to have a separate area where there's staff movement, elevators that are reserved for staff, staircases, maybe certain corridors that are reserved. It's more important for things like biomedical waste transfer. If you have soil linens moving around, you don't want it to have move around in the same area where patients are moving. So I think that's important. But like I said, Manipal, there was no such thing. In Medica, there is some amount of segregation. There are some lifts that are reserved for staff. But yeah, I think it's important to have some sort of a separation, because also you'll have, when staff are walking around, often during rounds, you want to continue discussions when you're going from, ward A to ward B. And it's better to have that while maintaining patient privacy. So if you have a separate area to walk through, that makes sense.
Okay, so the next question is by SOA SIT Saida.
The question is, how much does it matter to have a different circulation and experience, as you've already mentioned? Is there any specific space where you want to go before entering a ward, or in between space which is not a typical breakout space where you rest? Do you need an intermediate space between a ward and an OPD section or some word like that. So what kind of space do doctors and nurses need?
So I think most areas have a nursing station and a doctor station where there will be a computer or two so that reports can be reviewed prior to starting rounds, where imaging can be seen before starting rounds, especially in the ICU. The way it's often done is you sit around a computer first, the whole team sits around a computer, goes through all the images for every patient because you use bedside. But it's easier, especially in an ICU where there's so much action going on, that you do it a little away and then start going in. But I think it's also important in today's times to consider have a room which can be converted for donning and doffing, where PPE is worn and taken off. There have to be separate entrances and exits. Uh, I think something like that might be a good idea. Like, it doesn't have to be a room reserved for this, but it's a room that's available that can be converted. But from OP to IP, I think it's usually separated in most hospitals now. Your OP floor is separate, and you don't have outpatient areas next to a ward.
The next question is by SRM SEAD, Radha.
Okay, so do you have any suggestions that can contribute to the easy functioning of a hospital in terms of segregation and circulation of spaces?
Yeah, I think segregation is important because it also allows for things that should be together are kept together. So, for example, your OT, your operation theater suite should be next to the surgical ICU. So there can be patient flow to and fro, because if someone deteriorates in the ICU and they need to be opened up again, then they can be transported with minimum delay. Similarly, like, if you separate the surgical ICU, then you have your medical ICU with the associated wards next to it. So that kind of and your OBGYN and pediatrics together, because the kind of care that's required, your staff will also be specialized and they don't need to be strewn across the hospital. That kind of segregation is good. So I think it's basically that. And what I also found was that, especially now when we're changing the way things are, we're moving from converting wards into ICUs and ICUs into HDUs, and changing things because of COVID. We found that the ability to change areas easily really allowed us to grow our capacity in really fast. We were able to convert 80 beds that were general ward beds into 80 ICU beds. One whole floor was converted, and that was only possible because the design allowed for it to do so. So I think having rooms that can be used as donning and doffing, as I had said, having a separate entry and exit point, and spacing, because your requirement of space, ICU beds need more space around them, where general ward beds can be kept closer together. Things like that would help in easier functioning. And of course, there's the separate circulation for staff and patients that we spoke about.
Devi, would you like to go next with a question?
Yes. So this question is about pharmacy, placement of pharmacy. So what do you think, we have to place the pharmacy only in the ground floor, or it is important to place pharmacy like in every floor, or one for 2 or 3 floors, or in the floor which has the surgical ICU, operation theater, like that? So what do you think about it?
So I think having pharmacies on every floor would be wasteful for the manpower, because you need to have registered pharmacists and things like that. There are a lot of rules when you have a pharmacy. But I think more importantly, so the way it works in most hospitals is you have one central IP pharmacy and one central OP pharmacy. And there is an existing system that allows for transfer of medicines from these pharmacies to individual wards. And there's obviously an OT pharmacy, because the kind of things they need to keep are different. So anesthesia, medication, analgesics, whatever else, like implants, all of that is usually kept in the OT pharmacy. But all ICUs, emergency rooms, all of them have a store which is represented virtually on the pharmacy system, but it's technically just a storeroom which is accessible by the nursing team, where things that are used regularly in that area any emergency drugs that are used regularly in that area are stored there. And it's not a pharmacy per se, but it's a storeroom that's allowed. So that way, if you need anything immediately, it's available.
Okay, so you are saying it is for operation theaters and for emergency, uh, like
Yes.
emergency wards. There are special stores which has
Right.
the basic. Okay.
So there'll be an operation theater pharmacy, OP pharmacy, and an IP pharmacy, and all the other areas will have their own stores.
Oh.
So wards will have their own stores, ICUs will have their own stores. But this is like, normal, the saline that they use for IV, empty syringes, maybe antibiotics, some of the stuff that stays viable without, proper monitoring. It doesn't need refrigeration, this and that. They can be kept at the ward itself.
Abhinay, would you like to go next with a question?
So, how is the transition from an outpatient to an inpatient department made?
So in the hospital, there is a difference. We try to maintain a difference in accessibility of different areas. So outpatient would be completely open to public generally. Your inpatient would be open to the patients and their immediate family in a restricted manner. And your ICUs would be completely off limits, right? So that is the ideal situation. But most hospitals have grown organically in India. Most of them have add-ons. They keep changing things around. So this is not really maintained throughout. So, but ideally, what we would have is the common area, which is most accessible, is near the points of entry. So you have your outpatient clinics on the ground floor, and then your middle floors would have wards. And since we're talking about segregating specialty-wise and criticality-wise, you'll have, say, the medicine ward, and on the wings, like further out from the staircase of the access points, you'll have your ICUs. So I think that's how we usually go. And more than anything, it's the security guards and the admin staff who make sure that this accessibility difference is maintained.
Okay, and for a patient experience, if I come in for consultation and if I have to admit it, so what is that process like as a narrative?
So I think there's two ways of getting admitted, right? You can get admitted via the emergency room, or you can get admitted via the outpatient clinic. So when you get admitted via the emergency room, you'll undergo all your tests before you reach your ward. So you get seen by a doctor in the emergency room. They decide that you need to be admitted, and they write a bunch of tests. So all blood test samples can be taken in the emergency room itself. And then on the way up to your room, you'll stop at the imaging suite. So you'll have an X-ray or a CT scan or an ultrasound or whatever, and then move up. If you're getting admitted through the OPD, generally you'll be sent out to the administrative admission desk, where all the paperwork, insurance papers, all of that the formalities will be completed, and you'll be handed over to a nursing staff probably, or a valet of sorts, who will take you up to the ward. Again, it'll be different for a normal ward patient versus an ICU patient in terms of that.
Thank you.
SRM SEAD. Radhe, would you look? Yes.
Yeah. So for a pediatric hospital, should there be day spaces and play areas or rooms for the kids in the IPD? If so, how essential are those spaces for the kids?
I think it's very important. Hospitals are extremely scary places for children. Just the memories of getting poked and prodded and injections and things like that. So they don't really like hospitals. And I think in the outpatient area, it's even more important because they're waiting in line for their turn to see a doctor, which is just adding on to their fear and restlessness and things like that. So having some sort of a small play area where, basic stuff. We had like a small plastic jungle gym in KMC Manipal for the kids, with a slide and a couple of cycles they can ride on and things like that. So that sort of brings down the level of tension. And I think it's also important in the inpatient area, but care needs to be taken because you have patients who will be infective, patients who are immunocompromised. So care needs to be taken to make sure that these children are not intermingling, especially infective things like chicken pox or anything like that. They should not be using the same toys and things that the kids who are not infected are using, because then it's just going to be an outbreak. But I think it's important to have something like that, some colorful space where they can hang out.
Next is AUCE.
So, what is the current situation of robot-assisted surgery in India, and what will be its impact on influences in healthcare and healthcare and design services? So, what are their influence?
So I don't think robot-assisted surgery has grown so much in India yet. It's not that widespread. It's restricted to the more super specialty, more expensive places, because the kind of investment that goes into procuring Da Vinci robots and the training that goes into it is quite a lot. So I think it'll take some time before we're able to see it in every city even. But the changes are, I think we need a lot more space in the operating room when you're using a Da Vinci, because you need to keep rearranging it. It's basically 6 arms on like one pole that has like this huge wheel system that allows you to move it. But you may need to move it from one side of the patient to the other side of the patient, and that needs that amount of space around the operating table to allow for that, because in the OR you already have the anesthesia machine, which is a big system. You have the operating table, then you'll have a couple of tables on wheels where all the instruments for the surgery are kept, and those will be there even if you're using a Da Vinci, because the initial portion will require all that equipment. So having that much space around the table is important. And with the Da Vinci robot, you have these consoles where the surgeon sits, which are also quite massive. So you need to accommodate for that space, because at least one of those consoles are usually kept inside the operating room, so that the senior surgeon sitting there, in case there's an emergency and they need to convert to a normal open procedure, they'll be able to switch. So at least one of those consoles is kept inside. And you generally have an assistant console, which is used for both training and by the junior medical staff to operate. So that could be kept outside the operating room as well. But I think space would be the most important thing in terms of planning.
So, with spaces in the hospital, you need internal connectivity. Although it's not mandatory, yet important for developing a better design to regulate the flow of functions and activities better.
Okay. So I think a couple of things. So like we spoke about admission process and access to the CT scan room and things like that. In any emergency, when a patient comes in, you usually need some sort of imaging. If it's a serious case, so you need to have access to the CT scan room, which is the imaging of choice when you have an emergency, because MRIs take a lot of time. So having that clear pathway to the CT scan would be important. And secondly, an access to the operating room as well. So if you have an accident patient who comes in, you need to be able to move them either to the CT scan room or to the operating room very fast. So you don't want too many turns that need to be taken, too many elevators that need to be taken, and then you switch and move to the next wing before you reach the operating room. That's not a good idea. Besides that, I think the surgical ICU to the OT that we spoke about, the labor room and the operating room that OBGYN uses for deliveries, that being connected to the neonatal ICU is important, because if you have a premature delivery or if you have a child who needs immediate assistance, the staff that are trained to treat infants and neonates are different from your general staff. So it's not like an internal medicine doctor can just do it, like provide care to a child. It's not possible, especially with neonates. Even pediatricians have a specialization to treat neonates. So I think having that access to the neonatal ICU is important. And similarly, I think having a small pathology suite next to the operating room is an interesting idea, because you have things like frozen sections that are done intraoperatively, where a sample is taken and it needs to be studied immediately, and the surgeon is waiting for the report before either proceeding with the surgery or terminating the surgery. So either having a small room for that, or at least having a mobile unit, maybe, I don't know. And blood bank to all these areas is an important connection to have. So the ER, ICUs, the OT, and the blood bank should be connected. Doesn't have to be a physical connection, but at least some sort of a system that delivers it. I guess if you need blood samples to be delivered is important.
So the next question is there any protocol to manage situations during a calamity or a disaster like floods, earthquakes, etc.?
Uh, there definitely are individual protocols that hospitals follow. I'm not too well versed with protocols for floods and earthquakes and things like that. But we did have a cyclone in Calcutta recently, which we did prepare for. It mainly involved tying down things and making sure that. So we had a couple of porta potties on the roof, which they tried to tie down, which didn't work, and we lost those. And then we also lost a roof uh, because it was I don't know, it was an addition that they had done which they didn't do too well, I guess, and it was on the seventh floor, so we lost the roof of the conference room. But the protocol that was followed was to make sure that all the electronics and the TVs and the projectors and all of that was removed from the conference room. So there are protocols like that, but each hospital has its own disaster management protocol based on what they commonly see in that area.
When we're talking about emergencies or certain calamities, is there anything when it comes to a hospital and the hospital is facing certain mishap? So how do you evacuate the patients from the emergency wards or IPD sections who have not yet recovered, and where do you place them or relocate them?
I think unfortunately I don't have any experience with this, and I'm not sure. But I would guess that there would be a system to transfer them to a separate hospital. But when you have like a 400, 500 bedded hospital, it's difficult to have an alternate area in the immediate surroundings to move these patients. But what I've from what I can think, it would probably involve patients who can move and who are mobile will need to walk themselves through the emergency exits. But for people who are bedridden or in the emergency room and things like that, they will have to be transferred via stretcher through an elevator that has to be kept open, because you can't really uh, carry them downstairs when you have hospitals that are 6 stories tall and things like that. But I think most hospitals will have a protocol, but I'm not able to say any more on this because I'm not sure.
Next is SRM SAID.
So in case of in a hospital coming to the visual aesthetics and comfortability, what are your insights on experiential quality, lighting and materiality that's required in hospitals? Because for an operation theater, the lighting would differ, and in corridors or the waiting areas, all of that has a specific requirement or so it's like how does it differ?
I think operating rooms are kind of easy because you have specific surgical lights that you use, which come with the operating room setup, which will give you all the lighting you need. But in terms of OPDs and wards, I think you don't have requirements, but it's important again that natural light to just make it a better experience for both the healthcare workers as well as the patients coming in. Um, I think having a little more, I don't know, color, maybe some sort of a, like we have one rooftop garden in the hospital I'm currently working at, which is visible from some of the wards. So that gives you a little bit of comfort. But lighting wise, I think your restrictions or requirements would be there in the ophthalmology suites, areas where endoscopies are happening, areas where ultrasounds are happening, where you need to dim the lights. So ensuring that you have a system to make sure that natural light is also cut out and you can turn off all the other lights and use only your equipment lights. I think that's important.
And in case of emergency situations like COVID or natural disasters, where the doctors are expected to be in the hospital 24/7, so what kind of facilities should be provided to them in that case?
I think when it's things like this, I think you need to have the ability to put up more doctors, even if it means closing down a ward and converting it into living spaces for the healthcare workers. Because it's not just doctors that run the hospital. There's a huge number of nursing staff, a huge number of doctors, administrative staff, housekeeping, food and beverage. All of them need to be put up in the hospital. Like, for example, when the cyclone was predicted for us, the whole food and beverage staff stayed in the hospital overnight to make sure that in case they go home, and if they go home, they may not be able to come back to work the next day, which happened with a lot of people who did go home. So having that sort of flexibility to put them up. But for doctors specifically, I think on-call rooms are important. Having a space for them to sleep, obviously, but also having a space for them to have a shower before and after entering infective wards or anything like that. Having some space for them to sit in with a table, so if they need to work, read in the privacy of their room. All of that is important. But I think the alternate living quarters, if they're staying 24/7, providing that somehow is important. We actually took up a couple of guest houses around the hospital and converted them into living quarters for our staff.
Okay, next question is what should be kept in mind while designing a morgue in a hospital? For example, like storage units, room spaces, circulation, or facilities for the doctors working at a morgue. And how far should it be placed from the main hospital building?
So the important thing here is not all morgues perform autopsies. So it's usually government hospitals or teaching hospitals which have the clearance to do so. So for example, Medica doesn't perform autopsies, but Kasturba Medical College where I studied does, and it does perform autopsies for the whole region there as per the government mandate. So in that case, if you have autopsies being performed, that's the only point where doctors would be present over there. But otherwise, usually the morgue doesn't necessarily require doctors. So if you don't have autopsies being performed, morgues can be in the building. Even if autopsies are being performed, they're usually just hidden away so that it doesn't upset other patients who come in. So it's important to have an alternate exit for when the body is being handed over. I think it's also important to have a room over there for the families when they come and see their loved ones, for them to process the grief. If they can have a private room over there to process that. I think so like we spoke about the separate corridors or the separate circulating areas. It's a good idea to have something like that, because then when you're moving patients who passed away from one area to the other, it would allow for that to be done without the other patients and their families seeing this, because you have multiple floors with ICUs on different floors and wards on different floors. So you will have a lot of movement, and you want it to be as less visible as possible, because you want the hospital to be a hopeful place where everyone, that feeling is important. I think the other thing is figuring out the capacity for the morgue itself. So it depends on what volume of patients you see and how critical the patients who come really are. So if you're in a primary or secondary healthcare center where you refer all your serious cases to a larger hospital, it's unlikely that you'll see so many deaths in that hospital. So it doesn't make sense to, have a large capacity morgue. But it's also important, like during COVID, we had to get additional facilities because our morgue couldn't take the number of deaths that we were seeing. So I think that is something to keep in mind, assessing how many beds you have and what your likely capacity for the mortuary should be. Yeah, I think that's about it. But in terms of what the morgue actually needs, it's you need refrigerated storing space, and that's it. Yeah.
So the next cluster of questions are specialty related, where we mainly focus on pediatric, maternity, and psychiatric. So is there any special criteria that we have to adopt for the pediatric radiology department?
Okay. So in a radiology department, there is generally you have X-rays, CT scans, MRIs, and maybe ultrasonography. And X-rays, CT scans, and MRIs are the same for all kinds of patients. There's no size difference or anything like that. The one thing that is different for children is that they need to be sedated depending on how old they are because they won't stay still. But that sedation is generally via syrup or something like that. They don't need an anesthesiology setup per se. So I don't think you need that much different. You don't need so much different planning. The radiology suites are usually the same for children and adults. But for example, if you're doing a specialty radiology thing like a cardiac ultrasound for kids, then you usually have it in the OPD area because it's the same consultants who perform them. In India, there's no specialized pediatric ultrasonographers. The cardiologists themselves are trained to perform that. So having that sort of place available in the pediatric cardiology OPD or something would be useful.
So how important do you think a psychiatric ward is for a hospital? Like, is it necessary to have a psychiatric ward in a general hospital or a cancer hospital or sorts? Like, is it very necessary, or things can even happen without a psychiatric ward? And are there any specific requirements for a super specialty hospital which are not present at this time, but you think might be needed in future, like as time's evolving and as we are facing different kind of difficulties, like at present we are facing COVID. So are there any requirements which you feel are needed?
Okay. So in terms of psychiatric wards, it depends on what your capacity is to deal with psychiatric patients. So if you have a strong team that does good work with psychiatric patients, it depends on the kind of patients you see. So if you have patients who have diseases which tend to make them violent, or if they're majorly depressed and things like that, your psychiatric ward usually has this. There is a security issue with limited access, but unfortunately that also looks really bad. For example, in KMC Manipal, it was this top floor, tucked away in the hospital, which had a door which was card controlled access and a security guard there 24/7. It was almost like you enter and you never leave, that sort of a thing. So it's important to not make it look like that, but definitely there should be a security issue to make sure that patients don't harm themselves or others. I think again, natural light is important space for them, for patients there to walk around, group areas, because psychiatric wards often have group therapy activities as well as private activities. So having spaces like that, in a psychiatric ward like in Manipal, we have electroconvulsive therapy that happens, which requires like a minor operating room setup because the patient will be anesthetized by an anesthesiologist. So having a separate room with enough space to have the anesthesia machine there is something that can be done. I think suicide proofing is something that's an important thing to look at. So, weight limited hangers and, making sure that the windows are barred and stuff like that. Those are some of the things that would be different in a psychiatric ward. With respect to whether you actually need it, so at Medica, the hospital has psychiatrists, but we don't have a large setup for them. Since Medica does have enough private rooms and things like that, we have protocols in place that make sure that all these things are available to the patient. So we can provide 24/7 caregiver who will be at the bedside with the patient to make sure that they don't harm themselves and things like that. In terms of where we might be going in future and things like that, this is off my experience in America and what I've seen there. So the hope is that we're moving towards that because it gives you um, a lot more diseases that you can kind of tackle. So I think surgical oncology suites with attached medical and radiation oncology, because cancer therapy in general has three facets of treatment. So the chemotherapy, which is taken care of by the medical oncology team, you have surgery, and you have radiation oncology, where radiation is used to treat the patient. So having an area where all these three are available, because these three teams have to work in tandem to provide the best level of care. So that's something. Then we spoke about robotic surgery already, because we have evidence that robotic surgery is better for patients. In some cases, there's a lot of controversy also, but in terms of recovery period, like if you think about it, I've seen robotic surgery for cardiac surgery, and you can have a bypass surgery and go back home the next day. So that's where we're moving towards. So having operating rooms that can accommodate robots, that's something. Then the other interesting thing that's done is intraoperative radiation therapy. So, which means that when a patient is undergoing surgery, you provide radiation inside the body cavity. So the issue with that is it's radiation. So your OR walls need to be lead lined with a lead lined door, and you have to have the facility to monitor the patient without anyone being in that room. So doing that, or even having a CT scan inside the OR, which is often used by neurosurgery. So accommodating for that, again, there's the space issue and the lead line wall issue. I think, yeah, I think those are the main things I could think of in terms of where we could be going in the future.
So next, what do you think are the requirements for a rehab, and like what kind of wards or suites do we need, and how differently are rehab patients treated from the other patients? Like, and what is the environment you think rehab patients need, which is not being provided at present?
So I'm not so well versed with rehab clinics and things like that, but I think one of the things is, again, the security levels to ensure that there's no mishaps, the suicide proofing. But in general, you want to provide an environment that treats them the same as any other patient, or at least gives them a sense of normality. Uh, besides that, I think the group space for group areas as well as one-on-one counseling areas to exercise, maybe walk around, meditate. I don't know. So things like that would be important. Having different spaces which doesn't make them feel like they're in an institutional setup, but that they are moving back towards a normal life. That's what I feel should. That's how I feel a rehab facility should look. It should not be like a prison.
What's your opinion about integrating an outdoor space in a hospital planning, keeping in mind the gynecology or pediatric in context?
Okay. Can you just explain a little more what it means, or like what you're trying to look at?
So for pediatric, the children, in case they are in intensive care or like not ICU intensive care, but are in there for as an inpatient for a long term, then other than the play spaces or something that keeps them entertained, what is the importance of them breaking out into more natural spaces or outdoor spaces? Because being confined in a hospital for a long time tends to mess with the mental health. So how important are those, and how can we incorporate those spaces in a hospital?
I think it's a great idea, but it also needs to be controlled, because inpatient children, it depends on what they're receiving treatment for. So if it's pediatric oncology, for example, then they're going to be immunocompromised, and you don't want them to be exposed to infectious agents that might be present in an outside setup. But otherwise, I think it's a great idea. But making sure that it's controlled. So, for example, if you have an outdoor area, but it's more like a near the ward, and it's not, and it's controlled artificial grass maybe, or like whatever. But it's controlled. It should not be that it's like a park outside, because there will be the fall risk. You don't want a kid to get injured in the hospital. Things like that need to be kept in mind.
Okay. And how many operations does a surgeon do consecutively on an average per day? And if so, the doctors could be really stressed and like, need to relax if it's a lot. And what are the spatial suggestions that you would give for this? This is similar to the COVID question that I had asked, but on a regular context, how would it?
So I think the number of surgeries depends entirely on the kind of surgery that the surgeon is performing. For example, if you're doing neurosurgery or cardiac surgery, each surgery can last up to 6 or 8 hours, which means they'll do not more than 2 surgeries a day. But if you're talking about surgeries that last 2 to 3 hours, it can be anywhere between 6 to 10 cases a day. And consecutively, I would say that what we've usually done is that the time it takes to turn over the OT. So you get cleaning done, get fresh sheets in, get fresh equipment in, and things like that. That's the time we get to take a break. That is provided you don't have two OTs running simultaneously. So the other thing that happens is you have one OT running and the other patient is getting prepped in the second OT. So you move from one OT to the other, but normally just take a break halfway through. And the more senior you get more time off because you let the junior surgeons also operate, and you go in only for the major cases. In terms of what spaces they can use to relax, I think most ORs have a surgeon's lounge where they can kind of sit, comfortable chairs, maybe a TV, get their food and eat, things like that. So that's available in most places. And also having an on-call room in the operating complex is a good idea because you have a lot of surgeries that happen at night. So if you have accident cases that come in with head injuries, transplants for some reason happen only at night. So being prepared for that. So having an on-call room in the OT complex as well is a good idea. The difference is that the other staff who are not the surgeons, they have shifts which they can stick to. So even halfway through a surgery, your nursing staff gets to switch out, but the surgeons don't get to do that. And so this space is important.
Okay, so when you talk about certain isolation wards or isolation areas, today's situation is such that the entire hospital has to turn into an isolation hospital. But is there, as like today's situation, or maybe something for at a swine flu situation? So, is there a need of the isolation wards to be as open plan, as in that it could be moderated anytime and then got back into the same place as it was designed? And how should the connectivity be? As in, what do you think about it?
So there's multiple purposes for isolation wards. Okay, in immunocompromised individuals, like someone who has a very low white blood count, you need isolation wards, isolation rooms for them, where they're not in contact with anybody else. You use barrier precautions. Anyone entering the area will go through multiple layers of hand washing, wearing particular protective equipment, so they don't infect the person. Similarly for liver transplant, for any kind of transplant patient for that matter, because they're on immunosuppressants. So that is one type of isolation room. Okay. So there you want it to be an individual room, which is only for them and there's no other patient in that area. So that's one way of looking at it. The other kind of isolation area is what we're looking at today or during the swine flu and things like that, where you can cohort patients. So if someone is infected, they're infected, and keeping them with other infected people will not increase their level of infection. Which is why right now in COVID, you can keep 20, 25 COVID positive people in the same ward without that fear that you need to keep them in individual rooms and things like that. So I think it's important to be able to convert. For example, there is information that has come that you don't need negative pressure technically, but it's something that we have tried to do. So we managed to convert a whole floor into negative pressure by basically adding exhausts and vents and UV lights for the exhaust and things like that. It does drop. So the major issue we faced with that was a increase in the temperature because the air conditioning stops working as well. So that's something. But I think connectivity wise, you need for an effective isolation ward and isolation area, you need that ante room which is a clean area where a person is entering from, and then from there they go into the donning area where they wear the protective equipment, which enters into the ward, right? And when you're leaving, it's from the ward to the doffing room where you take off the protective equipment and out of this area. So that minimizes your the healthcare workers' exposure to the infection. So those are things that I think make sense for isolation areas.
Also, when you're talking about the anti area, there's a lot of soiled waste that is getting away, soil materials or soiled equipment. So what is the waste traveling system in the hospital? Does it have to go through the antechamber, or does it have to go through the IP or the isolation ward? How does it?
So the ideally the soil material should not come to the antechamber at all, because that's your clean area which you're entering from. It should exit from the doffing area, because most of your waste gets collected there except for the patient waste. All the protective equipment that you're wearing gets thrown in the doffing area. So there is a system of double bagging all these, especially infected wastes. They're double bagged and labeled. And once they're inside two plastic bags, it's not going to come out. It's not going to infect anybody out after that. So I think it's important for it to move in the direction of healthcare worker flow. So the person who's picking up this soil waste should enter through the antechamber, wear the protective equipment, pick up this material, make sure that it's tied securely, label it, and then it goes out to the exit. And from there, uh, the biomedical waste handling in most hospitals is very effective. They know how to deal with their waste, how to segregate it, and things like that. For example, to the extent of which all COVID waste is collected separately, uh, even by the company that processes our biomedical waste. So they have one pickup only for COVID waste. So I think it's just important to follow that same flow in your isolation areas, and it'll be fine.
Okay, the next set of questions are medical ethics related. Is there a protocol that is followed in conveying the news of a death to the family members of the deceased patient? And if so, should there be a particular room or a space allocated to convey the message?
I think having a separate space is very important. Unfortunately, it's not followed so much in India where I've worked. It's not given as much importance, but it's starting to happen. Most ICUs have a counseling room where the patient's family can be spoken to. Uh, so this is not just for conveying news of death, right? So even if you're giving a bad prognosis, like a patient has come in with an accident and you need to tell the family that things are not looking good, that's not conveying news of death, but it's as bad. Or if you have to tell someone that they have cancer or anything like that. So there is an ideal way of doing it. It's called spikes. It's a mnemonic that we kind of follow. So S is setting up the interview, so knowing where you're going to do it, making sure they're sitting down comfortably as they can in a hospital. Then P is assessing the patient's perception or the family's perception. So what is their current understanding of the situation? What do they think is happening? What is the last thing that someone told them, right? Then obtaining the patient's invitation. So do they want to know? How much do they want to know, right? For in India, like what I've found a lot is the family members say, don't tell them. It'll not let them recover. They'll just give up or whatever. So understanding how much the patient wants to know, obviously patient over the family, the patient's wishes matter more. So how much does the patient want to know? And then K is giving the knowledge and information to the patient. You have to maintain, empathy, understanding, but giving it to them clearly. You should not beat around the bush. So that is done. Then addressing the patient's emotions. Uh, so I think it's very important not just to treat the disease, but to help the patient and their family process what's happening and bring them to what their new normal is going to be. And the last is the strategy and summary. So after you're done conveying the information, what is the next step of action? What are the options? And summarizing the whole thing again. So because initially there is going to be shock, people are not going to be able to follow what's happening. Usually you need to talk to them multiple times. Just telling them once is not enough. So you'll have multiple sessions of counseling where you convey this information to the patient and the family and their options and what the future looks like. So, but I think each doctor has their own way of doing it. But this is the broad sort of way the best way to do it so far. I think I like the way this is set up.
So a very difficult job with respect to a doctor in person, with the staff in person who have been interacting with that particular patient. So how is the doctor impacted by a particular person's death or the bad news which occurs, and how do the doctors need the spaces which spill out spaces which would help them de-stress, or what is the current scenario in India about that?
It's extremely important for doctors to have that spill out space. What happens is in India, or in most parts of the world, even in America, that doctors aren't allowed to feel bad or feel affected, and that just leads to hardening. That empathy goes away, the sympathy goes away, and it's just like, yeah, you have this condition, we'll take care of it. It gets to that point, and that is something that bothers me, and it's something that I keep trying to not uh, that's something I don't want to end up as. But it's important to have that private space where, because when you think about it, the doctor is doing everything in their power to keep this patient alive, right? And it's not just the patient, because you're talking to the patient's family on a daily basis, and you have to have a good rapport with them to be able to convey these things. You're talking to them on a daily basis. So more than losing the patient, having that conversation with the patient's relatives is even harder, because and it after a point, depending on what you're doing, if you're a critical care doctor, you're doing it on a daily basis. So it's important not to lose that part of humanity that you have, where it's just like, yeah, I have to do this as part of my job. It shouldn't get to that point. So having this uh, space to de-stress, maybe even talk to somebody, or like, it's important to share. And this is something that you can share only with other healthcare workers. So having that private area where you can, talk about it and things like that is important. So I think ERs, the OT, ICUs, these areas should have such a space where a doctor can go and kind of let out.
Okay, so we have a question. How was the hospital? How has the hospital ward changed its layout post-COVID? How does the same space accommodate the sudden influx of patients and yet maintain the isolation required?
Uh, so at our hospital, I think everything was it was all on the go. We all kept just reading all the guidelines that were available. We started off with just 20 beds, so that wasn't a big deal. It was two 10-bedded ICUs that we converted into COVID areas. Irrespective of the severity of the disease, we were accepting patients only in those two areas. So with for that, it wasn't a it was initially a big deal because none of us knew what COVID would bring with it. So maintaining isolation protocol, having that entry and exit areas, assigning rooms for donning and doffing, all of that was difficult at first. But moving from 20 beds and progressing to 60, 80, 100, whatever, you start. The main thing was there are certain facets that are important to an isolation area working as an isolation area. So it's just the separate entry and exit, having the donning and doffing areas marked out, and ensuring that anyone entering that area is wearing protective equipment. So it's not like the virus is going to go through walls, right? It's going to be in the immediate surroundings of the patient, and then of course you need to keep in mind a general ward is not going to generate so many aerosols. So aerosols are the smaller droplets from coughing, sneezing, or intubating a patient or performing CPR. So that is restricted to your ICUs. So you need to take more care there. And then even more difficult than COVID specific spaces were the COVID suspected spaces, because there you're not sure the test result hasn't come back yet, but symptoms are common. So there you also want to protect the patients from each other. So in those wards, you want to have a segregation between the patients. You can't cohort them in those wards. So uh, eventually it just ended up, we just ended up converting areas because it's much easier to have a COVID only hospital. Honestly, like if you knew that all patients entering this hospital are COVID positive, then you take
Yeah.
precautions from the entrance and you're fine. But we have both COVID and non-COVID cohort of patients. So I think it's just controlling who can enter and who can leave. So we got really strict with that, to make sure that there's no untrained personnel entering these areas. But in terms of what changes, converting a ward into an ICU, it's you need lines set up for oxygen, which is not there in your wards usually. You need maybe dialysis lines, because COVID does affect the kidney, so we had to put in dialysis lines in the general wards as well. You also generally have a vacuum, a set of vacuum lines. So these are the three lines that need work. You need to break the wall and put these lines in, or like have them outside the wall. So those are big changes. And then deciding how far apart the bed should be placed. So if you have an ICU, you need more space. You may need a ventilator by the bedside. If you're going one step further and you need an ECMO, which is a machine that does the work of the lungs, then you need even more space, and you need two lines to operate the ventilator and a line to operate the ECMO. So that sort of stuff is important. And but besides that, I think it's slowly you get into the groove of converting wards into ICUs. Now our maintenance and engineering team is able to do it overnight. The other thing is obviously the ventilation systems that are present. So positive pressure, negative pressure, the ability to switch between them, and understanding the AHUs. Because if you have a COVID positive ward and a non-COVID ward sharing the AHU, that's a bad idea, because whatever is generated in the COVID ward will get sent there because of the whole recirculation that happens in the AHUs. So I think those are the main things that we had to look into when we were converting wards.
Doctor, can you also share with the students what does donning and doffing areas do? What exactly?
So donning and doffing is basically the term for wearing and taking off the PPE, and they are extremely crucial areas, because a mistake there would be the difference between getting infected and staying safe. For the donning area, it's when you're putting on all the different layers. So you need to definitely have areas for people to sit, because you'll be wearing the shoe covers, and these are usually like jumpsuit styled PPEs. So you can't really stand and wear it. You need to have a sink with soap and water, because you need to wash between steps. A mirror is important, because you need to make sure that you're covering all, as much of skin as you can. So those are the main things. And also space, because if you have a large ward, like the fifth floor ward for us is 80 beds of ICUs. So the number of staff that comes in during shifts to change is a lot. And then when you're going to the doffing area, the doffing process is even more risky than the donning process, because the outsides of your protective equipment are considered infected or contaminated. So there is a sequence that you need to follow specifically to take things off in a particular order, to make sure that you're not touching the infected surface with your hands. So there again, you need sitting space. The disposal has to happen over there, and that should be towards your exit, while the donning should be at your entrance. So that's there. Also, you need a mirror and things like that.
Okay. Thank you. I would like to request Jayant Sahasbudhe sir from PHCOA to unmute yourself and ask the question.
Yeah. Hello, everybody. Good afternoon,
Hello, sir.
doctor.
Good afternoon.
Mine was a very general. At the end of session, my request is, as a doctor, and what are your ideas about an model hospital, and in general, and in particular, are there any kind of spaces or systems or facilities which are not seen anywhere around us, not specifically in India or abroad or something like that, but maybe something like, in a sense that, see, we design a building which definitely lasts for at least 60 years, if not more than that probably, but the technology changes very fast and the building remains the same. So in that context, if some foresight is there and if something should be taken care of while designing an hospital, so it's a very general question, nothing particular. If you can throw some light from the point of view of a doctor.
Thank you, sir. So I think all the questions that have come in so far are great, because they all aim at improving the experience at a hospital.
Yeah, I know.
Hospitals are really cold, sterile places where patients definitely don't like being there, and the healthcare workers have to be there. So I think the questions are pointed towards making it a better experience for both. So that I think is one thing which is missing in hospitals all over the world, making it a nicer experience for people who are working there day in and day out, as well as for the patients. I think for me, what I felt from my time at this hospital is the ability to change, the ability to like convert areas and not being rigid with what it's been designed for. Like Sir said, there's infrastructure, technology, all of that is changing so rapidly. Hospitals as buildings also need to be able to change rapidly. So I don't know if there is a way to do it, but the ability to change the spaces allocated for certain things. Like right now, we're planning to convert an administrative suite into ICU beds. So like making that easier would be something that would be great. I think more space for I don't know, like I've not seen a gift shop in my hospital here, nor in KMC Manipal for where you want to buy something, flowers or something for patients. You don't have that inside a hospital here anymore. Um, Things like that. I think breakout spaces are important, places where you can comfortably sit, maybe a library of sorts for patients, or even the family that comes in. Small things like that. But I think hospitals have tended to be able to adapt with changing times, irrespective of when they were built. And hospitals are like, creatures that are growing, because any hospital you see in India, it's a maze. Uh, First, you have the main building, and then you decide that you want a surgical oncology suite, and a new building is set up. Your third floor connects to the fifth floor on that building, and patients and doctors both get lost regularly. So I think growth-wise and the adaptability is there, but I don't think any of us can predict what would be the need of the future. For example, right now, if you look at it, teleconsultation is the thing to do for everything. You're having so much development in teleconsultations itself. You have stethoscopes that can be there at the patient end, which the doctor can listen to sitting anywhere in the world. You have technology to look into a person's throat from your hospital room when the patient is still in his, uh, you know, house somewhere. So I think we'll be moving more towards this technology-driven medical care very soon. You'll have a lot more teleconsultations happening. Maybe your need for OPDs will go down. So the amount of space you need to dedicate for OPDs will go down. Maybe. Uh, I think those are things to think about.
Yeah, I really appreciate the suggestion of gift shop. It's a wonderful thing you told us. Yeah, it's very much needed.
Thank you, Jayan
Thank you.
sir. We have another question from PHCOA faculty, Joydeep Datta sir. So would you like to unmute yourself and ask the question?
Hello, hi Pranav.
Oh, sir.
Hi. Very simple question. It was at the outset. I think you've answered it largely. Do you normally, as doctors or other nurses, have a biometric area where you check in and you check out? And then the other question about donning and doffing, you've already said, but I just asked if you have separate staff changing or resting rooms separated for men and women.
So biometric was what we were following all across India, both in KMC Manipal and in Medica here. It was MCI required as well. The medical council wanted all the staff and PGs to log, and medical students, in fact, to log in their attendance via biometrics. Uh, Obviously, with COVID in mind, we've all stopped doing that. At Medica, we're using an attendance system which uses geofencing to make sure that you're in the location when you sign in and sign out. That's something that's being done instead now. But if you're talking about biometrics for access control, I think most hospitals don't have that much access control yet. But using a card system is a lot better than biometrics right now, especially in a hospital where even if COVID was not there, you don't want to track an infection from one room to the other. So a card system would probably play a better role. Donning and doffing, we don't have a separate male and female based donning and doffing rooms because all of it is done over your scrubs already. But definitely changing rooms for the staff, there is a separate male and female changing room, but not for donning and doffing. So they change from their normal casual clothes to scrubs in their changing rooms, where their stuff is also stored. And then they come into the before they enter the isolation area, you have individual donning. You have donning and doffing areas where both male and female can do, because it's over their clothes. It's not.
Right. Thank you, Doc.
Thank you, sir. We also have architect Nandini Bazaz. Ma'am, would you like to say a few words? Or if there's any question that has been unanswered from the chat box that you would like to say from the planning perspective?
Hello.
Hello, ma'am.
Hello.
Yes, ma'am, we can hear you.
Can you hear me?
Yes, ma'am.
Can you hear me?
Yes, ma'am, we can hear you.
Okay, so as I see it, there is a lot of similarity with respect. Yeah, so what I'm saying is I am able to see a lot of similarity. Also, as he has said that there are spaces which are compromised with respect to staff, which should have been provided. So it becomes our duty to look into these feedbacks, and we are then able to bring in quality and comfort apart from patients to staff also in the hospitals. The other thing I would like to say is that, as I mentioned, rehab centers, to add that with it, are looked at still areas where patients believe that there is a lot of guzzling of money by the hospitals. So these are really left aside. And also because mental health is a taboo in India still. When I was working abroad in Canada 15 years ago, mental health was a very large department, a whole floor of about 1 lakh square feet given to mental health and its rehab and its psychiatric divisions. But in India, it has not opened up. So yeah, that is where Pranav will be done this way, but it needs to be followed. It needs to not be locked away. So I think there is a good understanding of a practical view with the theory that I'm giving you. This talk has been very beneficial, I would say. Thanks.
Thank you, ma'am. There's one more question by Alvira Patel in the chat box. She's asking, are the donning and doffing areas anywhere linked to the clean and dirty utilities?
I think that the clean and dirty utilities aren't really linked to these. We tend to keep a separate room for donning and doffing just because we don't want anyone else entering there. If I'm understanding it correctly, then yeah, we have it's completely separate, and these are just individual rooms meant solely for this. So we didn't have donning and doffing areas planned in our hospital. So if there was some small room that was being used by uh, the food and beverage guys to heat the food before serving it to the patients, they were sent out, and that was converted into the donning area. And then the rooms that were used on call by the residents was converted into the doffing area because location-wise, it was the closest to the exit. And anyway, in the isolation wards, you're doing 6-hour shifts. So you don't need an on-call room in that floor itself. So I think that's how we used completely independent rooms.
If I may just add over here, if I may just add.
Yes, ma'am.
Hello.
Yes, Nandini, please.
So donning and doffing rooms are indeed staff change separate areas. What happens in an isolation is where an anti-space is given, that is really the nurse zone. the door to the patient is separate to the isolation room area itself. So the donning takes place in that ante-space as the nurse moves into the patient zone. So, and doffing also when she leaves. So it's required to be given a separate space. Also, when it comes to moving from staff change areas to OTs, operation theaters or operation rooms is the same thing. We have to really give separate change rooms and washrooms and a whole section which gives a one flow into, like you come from dirty, you go to clean entry. Now, clean and dirty utility rooms are totally away from this donning and doffing systems, because clean utility is where um, uh, elements which are of need and use to the patients, like bandages or clean sheets or cotton, are maintained in a clean utility space, which usually is next to a nurse station. And a dirty utility takes all that is thrown out by the patient by cleaning the patient areas. So it's like dirty, soiled either linen, or it's also dirty use like pads or napkins or diapers, or even from the OT, the dirty is different. So what I'm just trying to say is these zones and zones, dirty utility and CU, clean utility, are different functions, and donning and doffing are change and other areas for doctors and staff. They are not mixed at all. So when we share the space program, we will bring it out further. I hope I'm correct, Dr. Pranav.
Yes, ma'am, absolutely.
Okay, thanks.
Thank you, Nandini ma'am. We have one more question from Manikanta D from SOA SIT. So would you like to unmute yourself and ask the question?
Good afternoon, sir.
Hi, good afternoon.
Sir, I would like to know, while coming to the oncology department, like how the patients will be treated, like with the different stages. There will be some will be having at the final stage, like they won't have any no more options like that. And how come the spaces, like is there any separation of zones with the different stages, like patients?
So the thing with cancer is you don't technically need to separate them, because keeping different stages together does not affect in individual stages. But what generally happens is you would separate them based on the nature of the cancer. So suppose someone has a neurosurgical cancer, then probably all the neurosurgical patients would be kept together because of the kind of care that needs to be given. Similarly, if someone has orthopedic-based cancers, then you keep them separately. But I think it's an interesting thought that patients who are more advanced can be kept separately just for privacy, and they're in a different mind space, and that sort of separation is an interesting thought. But I don't think it's really followed.
Okay, sir. Thank you, sir. So while coming to the COVID and post-COVID situations, like any sort of changes is like you wanna suggest, like spaces, well, space-wise?
So as I said, I think the OPDs might become less, or the volume that flows through OPDs might drop a little bit. So that might change. So we are actively shutting down OPDs and keeping only a few open, both for crowd control to make sure that there's not too many people entering the hospital, but also because we're running teleconsultations mode, and also the ability to set up ICUs, wards, move them back and forth. That was an interesting learning in the COVID situation.
Thank you.
Thank you, Manikanda. Thank you. So with that, we are coming to the end of this session. I'd like to quickly thank you, Dr. Pranav. We extend our sincere gratitude for today's session.
Your answers to the questions were very well structured and delivered with extreme clarity. I am sure this session was really insightful for all the students who participated. We thank you and wish you all the very best for all your future commitments as well. I'd like to take this opportunity also to thank Nandini ma'am for preparing the students for this moment. These 4 weeks have indeed been a great learning experience in understanding the necessities, notions, and nuances that go into bringing hospital design into actual scenario. A big thank you to our 5 student volunteers, Devi, Sayeda, Alvira, Abhinaya, and Radhe, and their faculty. Your questions really voiced out the queries of all the students in this collaborative studio, and you moderated this session very seamlessly. Thank you. Thank you to all the students and faculty as well, whose interest in this studio helped us organize and facilitate this interaction session. Thank you. May I also take this opportunity to share with all of you that Dr. Pranav is actually the son of architect Geeta Balakrishnan, the founder of Ethos and ASEDGE. I'd request Geeta ma'am if she could speak a few words to both Nandini ma'am, Dr. Pranav, and also address the students once before we conclude the session.
Thanks, Navina. Today kind of made me realize how old I've got, particularly because I also got a message from JD. I don't know if, how many of you realize that JD addressed Pranav as Pranav and not Dr. Pranav. JD has seen Pranav, I think, when he was 8 years old or 9 years old when we visited. We did Argument at IIT Kharagpur. Those were the days my boys, Pranav and Gaurav, would be giving out audience prizes and things like that. So we've certainly come a long way since then. And yeah, so nice to see Pranav sharing on a different platform now. At that time, he was contributing towards Argument and being part of our events like the family was, but he's kind of associating in a different way. Feels good. Thank you.
Thank you.
Over to you, Navina.
Thank you. Yeah. Thank you very much, ma'am. Thank you, Dr. Pranav. Thank you all the faculty and students. Have a happy weekend and belated happy Teachers Day. See you all on Wednesday.
Bye. Thank you for having me here.
Thank you, everyone. Bye-bye. Have a happy Sunday.
Thank you.
If there are any more questions regarding the space, Architect Nandini Bazaz will take them over in our Wednesday regular sessions. Thank you.